Hey everybody, welcome to the last session of the conference. So this is the Assertive Community Treatment and Intense Case Management session, and let's go ahead and get started. So our panel today, we have Zachary Hicks from Choices. He is the ACT program manager. Is that correct? Yeah, okay, team lead. And then we have Delroy Duckworth. He is the ICM team lead as well. And then we have Susan Masante from the Division of Behavioral Health. And then we have Kelda Barstad from the Alaska Mental Health Trust Authority. And I'm not going to talk anymore, so it's all you, Zach. And then at the end of the presentation, we'll have questions and answers, and I'll walk a microphone around for everybody. So, yeah, or stand, either whichever.
So thank you everyone for coming. I'm going to give a kind of a brief overview of ACT. I'm imagining some people kind of have an idea of what it might be or what we might do, so I'm kind of going to go over it briefly and hopefully leave a lot of time for questions, because I think we'd like to talk about how to kind of implement those programs and get them going in maybe your community or even here in Anchorage. So the ACT team, we are a multidisciplinary team. We have 10 individuals, including a program coordinator. We kind of offer wraparound services for individuals who are experiencing severe and persistent mental illnesses, prioritizing individuals who are experiencing psychotic disorders. We have on our team, we have 4 clinicians, one who's a substance abuse specialist, we have case manager, we have a peer support specialist, a vocational specialist, and a housing specialist. And so, along with 2 RNs and a psychiatric prescriber. So the idea is that we are working with folks who are some of our most vulnerable in our communities, and we're bringing those services to them. A big difference in an ACT program versus a typical outpatient is that 70% of our services are expected to be done in the community with individuals alongside them. And we're also the frequency of contacts. So we want to see the individual we're working with 2 to 3 times a week at least, kind of normal visits, and we're also available for 24-hour crisis response. We are also able to kind of flex our schedules to meet the needs of our consumers, and so that might mean someone coming in on Saturday to follow up with a doctor's appointment or emergency medical appointment, or working late or early depending on the needs of those individuals. We work collaboratively, so every day we go through our entire client list with our team, so that everyone on the team is knowledgeable of what's going on with that consumer on that day. Which it's a lot of people. We have our capacity is 100 individuals. That's another thing that's kind of unique about the ACT program, is that our client to staff ratio is very low. So it's a 1 to 10 kind of ratio. And so each individual, they have a kind of a treatment team that's kind of based on their needs. So they might work with a clinician, vocational specialist, and a nurse primarily, but then everyone else is able to kind of step in and help out as needed, or to fill in those gaps because they're aware of what's going on through our team meetings. Let me think. Yeah, so that's kind of like what we do in a nutshell, in a day-to-day thing. It's very kind of our idea is that we're able to react to the needs of our clients in real time, and so we often set up schedules for the consumers for that day, but then we are flexible enough to kind of meet the needs of the people who are coming on throughout the day. We have a couple rule-out things based on the fidelity models of ACT and kind of the evidence-based practices. So someone who's a primary diagnosis of substance abuse would not necessarily be appropriate for ACT. We do work with many people who are dually diagnosed, but their primary issue that's kind of causing the functional impairments and the difficulties would be more of a mental health, a behavioral health disorder. So that's kind of an ACT in a nutshell. For our community, we kind of adapted it because there's kind of some models, that we follow the fidelity, but then kind of adapting to the needs of our community, whether that's times we're working or kind of how we're staggering in our intakes and things like that. So, yeah, that's kind of all I had. I wanted to leave time for questions. I don't know if we just pass on to Delroy.
Yeah, just pass on to Delroy.
Right.
Hello, my name is Delroy Duckworth, and I work alongside Zach at Choices as the directing clinician for the intensive case management program. Before I worked in this position, I was working as a substance abuse specialist with Zach on the ACT team, and then I moved over to the ICM program. So I will give you just a synopsis of what the ICM case management, intensive case management program is. I made some bullet points to help me to remember some things I'd like to mention. First of all, it's client-centered. Therefore, we work with the client from where they are. We approach them according to their points of their needs rather than what we think is right for them. We work with clients who are diagnosed with mental illness, substance use disorders, or if it's a co-occurring disorders. And we work with them from that point to help them to move along their recovery, utilizing treatment approach such as motivational interviewing. We engage with clients through referral from other agencies as well as walk-ins. And first thing that we'll do is that we will get collateral information if they have had previous treatments. Sometimes they may not have been involved with any previous provider. And so the first thing that we'd do, we would get collateral information. If they don't have collateral information, that doesn't mean that we will not serve them. We'll go ahead and based on their needs or based on the acuity of how they present, to determine whether they will meet criteria for the ICM program. Sometimes their diagnosis might be at such an acuity that they might better fit the ACT program, and so we would refer them to the ACT program. Or they might not need intensive case management, so we would refer them to like peer support. And so first thing we'll do an integrated assessment or mental health assessment to determine the level of care and follow through with a treatment plan based on what they would like to work on. Most time we see clients are presented with need for housing. One of the first goals that you might find clients say is that I need to get housing, or I want to find an apartment. I want to get off the streets. I want my own place. And so that is one of the first goals that we often see clients present with. The second goal they may present with is that I want to stop using, or I want to get help for my addiction or for their drinking. Third thing that we might see is that they want to be employed. They're seeking employment, or they want to go back to school. Fourth thing that we see commonly is that they would like to get medication management for their mental illness. And also they may add that I want to get counseling for their traumas. We have seen a lot of people who have presented with a lot of adverse childhood experiences, a lot of abuse, a lot of trauma, sometimes a lot of traumatic brain injury. We've seen that also a lot. So we would formulate a treatment plan based on what the client presents as their needs in collaboration with what's recommended according to the mental health or integrated assessment. And we would then assign the client to work with a case manager or a recovery coordinator. And our ratio of staff to client is in the intensive case management program is 1 to 20. So one staff would manage a caseload of maximum 20. And so we would also start providing services by coordinating with other providers in the community, because we know we can't do it alone. The needs that they have exceed what we can provide. So we would collaborate with other agencies in the community. For example, we may collaborate with an agency that provides supportive employment. And supportive employment, that's a very needed and very helpful service that we utilize. We have seen clients, for example, that have not worked, say, for 2 years, connect them with supportive employment, and they've been working, and it's really good to see that, and they come in and say, hey, you know what, this is my first paycheck. I worked this many hours this week, and it's good to see that, and to see them moving along, having a better quality of life. We also coordinate with other service providers that provide psychiatric services for medication management. One of the challenges that we have also seen is finding psychiatric providers for medication management. That can be a barrier at times. We address their mental illness, their substance use disorders, whether it's co-occurring or independent without substance use. We address homelessness, vocational goals such as employment, educational goals, connecting them with resources that meet immediate needs. They might come in not having food, so we would connect them with a food bank. They might need a bus pass for the day to get to a food bank. We would provide them with services such as that. The modality of service that we provide case management, we provide comprehensive community support services, which if I'm sure that you're familiar with that, whether it's in individual case management services, group, we provide groups. We also provide individual psychotherapy, and we provide medication management. Some of the barriers that we have seen barriers such as legal history, where that present as problems for people who are seeking housing and not having a good reference for a landlord. We might find that also with employment, and therefore this is where advocacy comes in important for clients that we're serving in this capacity, because we connect with landlords. There are certain landlords that we have worked with over the years that we find that they are open to work with people that we serve, and so we advocate for those clients and help them to create a rental history, and from there they can go on to other landlords with that kind of rental history being developed. So this is just, like I said, a synopsis of what we do in intensive case management. And if there's anything that you would like to know more during the question and answer time, then you may present those questions. Thank you.
Thank you. Good afternoon, and thank you for sticking with us. The last session is always hard to keep everybody awake and in the room, but I don't see anybody snoozing, so thank you. I'm with the Division of Behavioral Health. I am in the treatment and recovery section, and my little unit is called Recovery Supports and Services, which I'm excited about because it really describes what we do, which includes most things related to housing for our clientele, employment that you so nicely explained the importance of, and recovery services, including we are in the process of developing a certification and training for peer support specialists, because we think that's really important in a recovery-driven system. So I also happen to be the program manager for the ACT and ICM teams in Anchorage. They're the only two of that type of services that we have in the state right now, but we have lots of interest, which is why I'm really excited to be here this afternoon. I wanted to make just a couple of general statements about ACT and ICM, which may also apply to other types of services. So the first thing I want to say is that a top-down vision really impacts on the outcomes of the people that you serve. So if you have a top-down vision, meaning within your organization, but also it goes to the state, if you have a top-down vision that you're going to maintain and stabilize people in the community, you will likely maintain and stabilize people in the community. If you have a top-down vision that people will recover and can recover and are likely to recover with, the appropriate supports and services, you're more likely to have people engage in their full life and have levels of recovery. So I always like to remind folks of that. And I think it's pertinent to ACT and ICM, because ACT and ICM, they're really interesting programs in that they're in the community, they're not in the four walls of an office, which is really what makes them effective. But they also are, like so many of our behavioral health services, disease-driven, so we sometimes lose sight of the fact that people do recover, and even people who we think have the severest of substance use and mental health disorders and disabilities. So I just like to remind folks of that. The other thing that I hear in particular about ACT teams that I want to speak a little bit about is that sometimes people say they're coercive, and in some states they have been linked to outpatient commitment, or also known in some states, we don't have this here, but it's one of the criticisms that ACT teams can be, that particularly ACT, not so much ICM. And I want to speak to that a little bit, because in fact, our ACT team is not coercive. It is, and the ICM, as Delroy said, is person-centered, person-driven. Everything is by choice. So the point of these programs is that services and supports are offered assertively. The responsibility is on the team to offer them assertively, and that's what makes them work. And in fact, there's higher rates of good results with these types of programs when they are voluntary. We also, and this applies to both ACT and ICM, we also do this within the context of a housing first philosophy. And what that means is we assertively offer the services, whether it be through an intensive case management team or the assertive community treatment team, that we offer the services, but we do not deny housing based on someone's substance use or not, for example, not wanting to take medication. That's not how it's determined as to whether the housing is offered. If somebody says, I'm interested in housing, then we say, well, how are we going to go about doing that? And we also treat employment the same way. We are an employment first state, so we offer employment, as both of these programs do. So those are just some general things I think about when I think about ACT and ICM. I did want to talk a little bit about how it is that we came to fund these two particular programs, because I think some of you are here because you're interested in seeing ACT and ICM in your own communities. And I know we've been getting lots of questions about how can we start an ACT team, how can we start an intensive case management team. So these two particular teams were really through a grassroots effort in Anchorage. The Fairview Business Council and the Fairview Community Council really wanted to impact on the homeless problem in Anchorage. And they lobbied pretty heavily with the legislature in order to get funds to target for Anchorage to help with the homeless population, and they were successful. It was really a great grassroots effort. They were successful in getting, oddly, capital funds, because usually when you think of capital, you think of building bricks and mortar, but in reality, they also can be used for startup funds, so that's what they got. Now, the problem with capital funds is that they don't go on forever. So there's either time limited, or sometimes you can roll it over until you're out of your startup period. So that's how the initial funding came through for these programs. Then that funding was awarded for oversight to the Division of Behavioral Health, because we were targeting people with serious substance disorders and serious mental illness. The ACT team, as Zach said, is for people with serious mental illness using institutions. The original ACT teams out of, I always forget, Wisconsin, right? Wisconsin? No, did I make that up? No. Sorry, Stein and Test. Oh, I'm asking the wrong guy here. You're not old enough to remember. I am. So Stein and Test, and what they were trying to do, they were grappling with the deinstitutionalization. So people were coming out of the institution, but then they were ending up right back there because there weren't community services. So they tried to come up with what they called hospitals without walls. So, you know, it is sort of a medical model program because it started out as hospitals without walls, but they assertively went into the community and worked with these folks. Intensive case management has some different beginnings, and that's targeted for people who with primary diagnosis of substance use disorder, but both have been very effective. The funding started with capital funds. But in addition to that, our partners at the Trust and DBH also put some operating funds to it. I think because some of you, I believe, are interested in having these types of programs in other communities other than Anchorage. I do want to tell you that the state DBH is interested in growing our ACT and ICM programs. We don't currently have funding for that. As you know, our grant structure is really kind of challenging these days. And we're still in negotiation with the 1115 Medicaid waiver, but it has been proposed that both ACT and intensive case management be a service provided under that waiver. That being said, startup costs will be challenging because, as you know, we don't have a lot of grants to that end. So we have done some looking at numbers of what does it cost for some of these programs, and I have never seen an ACT team operate on under $1 million. Usually it's higher than that, but I just put that out there. ICM does not have as many of the, doesn't have the requirements of having a prescriber, for example, and nurses like ACT does. So ICM teams can be less expensive to run, but they then don't have the full range of in-house services. So it's connecting with those services, so coordination is really important. Startup for ACT, and probably ICM as well, is challenging because if the community wants to start a program such as this, and the startup, you can't onboard 100 people at one time, so it's a 4 to 6 onboarding. So if you're relying on Medicaid, you really do need to have some kind of reserves or startup funds. So that's just, I just said I'd do a little bit about the history and cost and funding, and so that is all I have about that, and I'm going to pass it on to Kelda, and then I'm glad to answer when we get to the question part, any questions you have.
Thank you. Good afternoon. I'm Kelda Barstad. I work for the Alaska Mental Health Trust Authority. I'm a program officer with the focus areas of housing and long-term services and supports. And like Susan, I'm assigned to the ACT ICM project. It is a project that the Trust is currently funding and does plan to fund in 2020. We already have our budget signed, so I can say that with confidence. And I just want to take a moment and identify how humble folks at this end of the table are. This is a life-changing, life-saving intervention. This makes an immense amount of difference in the community. The impact is huge. And the individuals that are touched by the workers on these teams and the communities that interact with this program have such positive outcomes. And it is phenomenal. So from this big level up here, I don't get to do direct services anymore. I'm more on the macro side of things, which definitely has a lot of positives too. But hearing the stories, it's phenomenal. Thank you for all of the work that you're doing and providing to the community. And And I think that's why there is so much interest across the state in these services. The ACT teams help some of our most vulnerable individuals through some of the most difficult times of their lives. And the intensive case management does the same thing for folks who may not have quite as many needs happening at the same time, but still need a lot of help. More than the average case manager has time to on their caseload, more than a by appointment service can figure out how to schedule. These folks are creative. And when they say they meet people where they are, that is a true statement, and that is all over town and all over the place. We're talking about on the street. We're talking about in their homes, if they have a home. We're talking about in businesses where that person may be experiencing a crisis and needs help right then and there. It could be at a food pantry. It is literally anywhere where that person is. They can count on these teams for support to help them when they need it. And that's phenomenal. And that's phenomenal for the group that's helped, because those folks have fallen through so many cracks. They've fallen through the regular service system, they've fallen through the safety net, and then probably got re-referred to the regular service system, and again, fallen through the cracks. So these are folks that are used to not getting served how we usually refer folks. It doesn't work out. And they've been disappointed by that process because it continually doesn't work out. They just don't fit into how services are normally delivered. And that's okay, because we have a service model to really get there and match folks and figure out, okay, what do you need today? What do you need right now? Let's work on that. Let's start there. Yeah, there's probably a whole laundry list of other things that are going to need to happen. But let's start with today. Let's start with right now. Let's talk about what's going to happen over the next hour. Let's start there. And that's incredibly powerful. And on top of all of that amazing person-to-person connection, high-quality clinical services that are provided, all of this is evidence-based. And we have data to show that if you're following the model, you're going to see people remain in housing longer. You see people with fewer severe symptoms. You see people employed. You see people with better relationships. And for the community, for fiscal folks, you're going to see a decrease in interactions with emergency services. So there's a benefit all the way around to working with folks, some of our folks that we're like, how can we help this group of people? We've tried all of the tools in our toolbox and nothing seems to work. Well, this is another tool. And this is another opportunity for outreach, to engage people, and to figure out how can we help this group meet their goals. And you can tell I'm really excited about this program, because I am. It's life-changing. And I'll say it again, it's life-saving. We have a lot of folks that come in crisis, and they're in crisis a lot. And these teams help create a new normal for people, a better normal than constant crisis. And it's amazing the transformation that occurs. So from a funder's standpoint, from this level way up here, when you hear about those changes, and you hear about the changes that occur not only for the individual, which is what truly touches my heart, but also how it can transform systems when you're matching services to people, how they need them, where they need them, there's less of a burden on service systems that aren't created to accommodate this high level of need. Your average case management program is going to have difficulty. If you have 60 or some odd people on your caseload and you can see them about once a week, and for the most part they're doing pretty good, they don't need a whole lot more help than that. That's not this group of folks. This group of folks is always going to feel taxing to that structure because that structure is not built to serve someone who has intense needs. This service is. So services will get some relief from that because the person that has the intense needs is going to be paired with an intense service that's structured to accommodate those needs, to accommodate, hey, I need a phone call every day. Hey, we're gonna see each other 2-3 times a week. Maybe if this week's not so good, maybe we're gonna see each other every day. For regular case management services, that's just not possible. If you have 60 folks to help meet their goals, can't see everybody every day. It's just not physically possible. Or if you do, it's for a couple minutes, and that's not very meaningful. So it adds another tool to the toolbox. And then that macro level on a community scale, just like Housing First, permanent supportive housing, these interventions that work to provide stability, to offer opportunity for change, you'll see that decrease in crisis services. Because now you have an opportunity to interact with people in a planned way and help people person to person with that crisis whenever that person needs it. And they probably didn't need to go to the ER. That person just got triggered by something and forgot the steps so that they can get back to good and move on with their day. But they can contact their clinician, they can contact their case manager. The case manager, clinician can help talk them through it. Say, okay, I think I know what's going on here. Do you remember your steps? Let's go through them together. Do you need somebody in person to help you through this right now? No trip to the ER. Nobody's calling the police to remove somebody who is having some active behaviors off their property. It's dealt with. The person moves on with their day. They get to do other things. So from that funder's high-level view, it's amazing because it can change communities. So I so appreciate the work that is happening in Anchorage. I'm really looking forward to seeing what happens across the state. I think that the 1115 waiver is going to offer just a phenomenal way to crack open the availability of this service to different locations that are interested in it. We are all waiting to see what the final outcome is. Unfortunately, we can't give you a timeline or identify a when or a how. But I do know that the trust is committed to the ACT services. It very much is in alignment with our funding passions. It helps to prevent the institutionalization of our beneficiaries. And for folks who aren't familiar with the trust, and I'm sorry, I really am very passionate about this service. I forgot the little explanation of who the trust is and why we exist. We were put in place actually when Alaska was a territory to help bring people back from out-of-state institutionalization. Our purpose is to set up mental health systems so that people who are institutionalized can come back to their communities and enjoy healthy lives and success and progress for their own personal goals. And we still follow those efforts today. And today our beneficiary categories have 5 different groups. And those are individuals with a serious mental illness, substance use disorder, traumatic brain injury, intellectual and developmental disabilities, and Alzheimer's disease and related dementia. So we work for innovation and changes in the service system that benefit our beneficiaries, create a more comprehensive service system to assist people in meeting their life goals, and ultimately to prevent institutionalization of those populations. And with that, I'll pass the mic off to Mike, or Mike has a mic, and what's your show? What's next?
All right, so we're ready for questions. I know there's got to be some out here.
Hi. So I'm very familiar with the ACT team, but we haven't heard really anything about the intensive case management team. How can you give a history of when that started here and what efforts are to educate your community partners on the services that are available?
So the intensive case management team started under the same initiative as the ACT team when the Fairview Business Council and Community Council advocated to have some funds legislatively put into the community, and then they kind of put them under the management of the Division of Behavioral Health. And what we decided to do is to develop a program that we knew was effective through research for people who were overutilizing, for example, API with serious mental illness, and that is primarily the who ACT is for. But then the intensive case management was the other part of the funding that was really geared for people who were struggling with substance use disorders. So they started around the same time, and that's the history, but we all came after that. So we weren't there. I don't know if you have any words.
That's good. That's good.
So to kind of speak to your questions about the ICM, it was actually, Choices has somewhat recently acquired that portion of the thing. So we had been the ACT team for going on 3 years, or at 3 years now, whereas the ICM, we've only been since February, I think, active at our December, but with, as far as kind of getting things started and going. So for Choices, it's a relatively new program.
All right, who's next?
I think there's always a tension between what is primary mental illness and substance abuse, right? I mean, we're all shaking our head because we know that if you meet someone on the street who has psychiatric symptoms but is also using, that kind of defining which problem is primary is difficult. And I guess I'm wondering if by splitting them and having ACT kind of primarily focus on people with primary mental health issues or primary serious mental illness, you might be making some artificial distinctions that don't necessarily need to be there.
So when we work with clients with co-occurring disorder, we address both issues. Some clients may present more with mental health symptoms while still have a secondary substance use disorders. So, for example, on the ACT team, there's both a mental health clinician and substance abuse specialist. So those two team members would be working with that client, for example. On the ICM, if the client presents with a co-occurring disorder as well, and the primary diagnosis is the substance use disorder, then we would also work with the client addressing both issues. Sometimes the substance use disorder might mimic some of the symptoms of the mental illness, and therefore it's important to get that under control so that we can clearly see what not substance-induced symptoms.
And also, too, it's not so much a matter of categorizing it one way or the other. A big difference between our programs is more about the functional impairments and like the high utilization of services. So someone may come in and you could say, oh, this is primarily substance use, but if they're going to API for long periods of time, multiple times a year, if they're going to the ER once or twice a week for a month at a time, those would be more appropriate for ACT. So it's not just the distinction of this or that. It's more of like, what is the functional impairments related to both of those things? And so that is more of the distinction we make as far as in-house. And also we're looking at individuals that we do a lot of time doing assessments and reviewing records, and so that we're getting people who are appropriate for that level of care. So someone's needs, regardless if it's mental health or substance use, could be met at a lower level. We're going to prioritize those individuals who are more vulnerable, and that's evident not just in their diagnosis, but what is actually impacting them in the community and their functioning, and how they're able to access resources. Are they able to take a direction or work with the case manager and then follow through on their own going to the APA office, or are they going to need someone there to help them talk to the person there to help advocate for their needs? And so that's kind of more of what we're looking at versus this is more your issue or this is more your issue.
Thanks. I think it's super important because, we experience a lot of times people with psychiatric symptoms going to the ER, going somewhere, and they say, well, this is a drug issue. And then, the treatment systems for substance abuse emergencies are not as robust as for mental health emergencies. And then the person doesn't get what they need. And so and it sounds like you're doing exactly what someone would hope a person would do, rather than try and kind of split them up so that you could move people over here for a different kind of intervention that often doesn't get as much funding, as much support as mental health interventions. So thank you.
All right, who's next? Any other questions? There we go.
So this is a question for Kelda. So, I don't remember the name of the person from DBH. Susan, thank you. Okay, so Susan was saying that funding is hard to come by to continue the program or to expand the program outside of Anchorage, and then you came next and said that the trust had decided they would fund these programs. So where is the trust going to be doing this, and with what provider?
Sure. We're continuing our existing funding commitment. So it's expected in the future that with Medicaid dollars that funding can be leveraged to expand. We also work with the department to apply for additional grants. So part of the work that we do is to provide technical assistance and grant writing assistance so that additional dollars can be leveraged and brought in. And I believe that periodically there are applications for ACT, and the department did apply for the last round but was not awarded. So we're hopeful for greater success in the future and that we'll be able to expand accordingly.
All right, any other questions? I have Sharice's got one too. I bet that we're thinking the same questions. We work in the same office, so.
All right, so this conversation about ACT and ICM has been really hot in Fairbanks community, which I guess is probably just pretty common everywhere right now because it's such a great thing, like Kelda was saying. One of the questions that we keep running into, and any one of you could speak on this if you have any knowledge regarding it, is the recruitment process for professionals in regards to an ACT team, because we know that the licensing and credentials for individuals part of a ICM team is not nearly as lengthy and drawn out, and as we all know, a higher licensure or professionals of that status are harder to come by in the state. So if any of you could talk about how that kind of went down when you guys were forming ACT, I think I would appreciate that.
So how we did it at our agency and how it was kind of when we got the grant was it truly is an interdisciplinary. So not everyone in there directly came from a background in mental health. So our housing specialist was a property manager, had worked in housing programs and things like that. And then, same with a vocational person. And so it really was bringing in outside, and that's to also be outside of that traditional medical model, because often, and this is just my own opinion, that people who are kind of ingrained in a very traditional office-based service often have a hard time adapting to the kind of service we did, that side-by-side therapy versus that across the table, right? Where you're actually in the community, in their home, on their couch, talking to them. From my experience, people who have been in the kind of that traditional mental health system for a long time have a hard time making that adjustment. And so bringing in those outside influences and those people from different perspectives not only rounds out the service we provide, but also kind of made our recruitment process somewhat a little easier, because you're only looking for very specific, those kind of clinical staff or those people who need those certain credentials. So that was one way we did it. But at the same time, we've also struggled with times when we need to fill positions, and that's, I think, across Alaska is an issue of just people who work in these fields and who are able to meet the level of service required. So it's an ongoing thing as far as that, but really rounding out that team where it's not everyone's coming from a very, I went to was a clinician, I did this and that. It's kind of having that different perspectives and then using that team approach where it's very linear. It is also helpful to have peer supports on the team as well, which is something that has really kind of made our service delivery much better, because one, we have someone who can relate to clients, and who also is coming from a different perspective of what that service might look like to me, right? And that has been a very kind of crucial part as far as the team development and bringing people in as well. So we've also been somewhat lucky is that we've had, I think partly because of the uniqueness of the job, is we do have turnover, but it's also some pretty stable staff members there from the very beginning. People who really believe in what we do, and as we're talking about the results, people see the differences, right? You see people grow, and these people who have often been cast out as kind of, well, there's kind of nothing we can do about them, and to see that change, it kind of keeps people motivated in the field and kind of keep going with that.
Perfect. And for the record, that was the same question I was going to ask. All right, who's next? Oh, there we go. Not sure who was first, so.
So the licensed professionals on the team, who do you have, like, from the healthcare, mental health care team, or who are, did you say nurse practitioner, or what all?
So we have two nurses, and so this kind of asks two questions. One about how we did it. We actually changed the original requirements for the ACT program was to have 3 nurses. We thought, based on the needs and what we could fill the gaps with other individuals, that we could get by with 2. So we could then hire a case manager, which was a much, not easier to find, but it was there wasn't that requirement for the licensure. We have 2 registered RNs, a psychiatric prescriber. We've had an ANP as well as a doctor during my time there. And then as far as just master's levels clinicians is for the direct service providers. And so that was one way we adapted our program to kind of fit more the needs of Alaska, was to remove one of those licensed positions so that we could have more people available and have people be able to serve right then.
Is your psychiatric prescriber out in the field as well?
Yes, so they're going out to people's homes and doing those assessments and those medication management visits with the person there. We also do a lot because we're able to transport individuals. We can bring them to the prescriber as well. And then we also do medication management services. So our nurses package medications, get them ready for delivery, and then we're able to go out to people and provide those medications in their home. And so that's one way we can do that. We're also going back to kind of the keeping people engaged. When people do happen to go back to the hospital or something like that, we're able to go to the hospital and see them there, kind of help them with their process of discharging so that they have a connection before they leave. We often pick them up from those places to keep that connection with their providers intact, rather than, oh, you were gone for 3 weeks, and now you come back and go to an empty home and no one's there, and it's Sunday and I don't know when I'm going to see the person next, and things like that.
Thank you.
So my question is, if each of you could give one piece of advice to those of us who are interested in, starting an ACT program, what would that be?
Just one?
Or two, whatever.
Was this specific to ACT or ICM? I forget.
ACT.
Okay, so before I became involved in any ACT teams, the trust, but prior to Kelda's time, they spent a fair amount of money and time researching ACT, and we visited teams in Vermont and Washington State. Vermont, for me, was particularly enlightening because it's got larger geographic area to cover than, say, like a team in Seattle or some, a city like that, or Anchorage, really. But I would say visit a team, and if they allow it, attend a morning meeting, or not morning meeting, a meeting. I guess you'd do it whenever you want to do it, right? I always think of it as a morning meeting. And the other thing is when costing it out, because this is really a big deal, when costing it out, you kind of need to know your ongoing operations costs, but you then really need to look at your first 2 years, maybe even 3, because that's startup costs, and it might include things like purchase of vehicles, buildings if you don't have a building. It depends on if it's a larger organization, what resources one has or the community has that they can put to it, such as doctors and nurses. And so those would be the 2 things I would say.
Well, I've also worked on the ACT team previously, and one of the things that I could advise is that know that it's not a traditional way of providing service, that it's very different, it's very dynamic, it's multidisciplinary. You have different people from different backgrounds coming together to serve different individuals. Sometimes 3 people is on the sub-team working with 1 individual, and know that the person that you're working with, your team members, they might address things from a different perspective because their background is different in their training and their experience. But there is a point where you collaborate and for the benefit of the person that you're serving. So to be aware of that, that team cohesivity takes time, and not to give up on each other, not to give up on your team, but to allow time for you to be able to develop that cohesiveness that will help your team be productive.
This is for the startups, correct? When you're getting started, how things...
Just in general, like what would be the most important thing you'd want to pass on to?
Yeah, so one of the most important things would be kind of following those standards. This is an evidence-based practice, and so I think that what has made our team successful is that from the very beginning, we were all well versed in kind of what we were trying to do based on the model that has proven to be effective. And so that means not shortening to, it's easy to be like, well, let's skip our team meeting today where we review all the clients. We're at 80 something right now, almost 90. That's a lot of people to do in an hour, especially when you're doing it every day. And so it's easy to be like, well, let's skip Friday and just go out and start working. But really keeping true to those, there's a reason for all these different things. And it's been kind of practically over 30 years, 40 years now. And so that's one big thing. And the other thing is being out in the community, making those connections with other providers and landlords and other people you interact with, because I think that is often people don't necessarily understand what you do. And so there's a constant education piece with people, and as well as with just kind of showing that you're consistent. So we've had many landlords who have maybe evicted clients we've had or want to evict, but they see us there, they're doing that, and now they're calling us asking if we have potential tenants, because they see that even though we might have individuals who have some difficulties at times, that there's a support team there, and they'd rather go to someone that they know is going to be there and support them rather than someone unknown. And so that's kind of going to the different, kind of keeping that communication with the community providers and the people that those consumers may interact with frequent and often.
Okay, next question.
So am I understanding that the ACT team is for people that are housed and the intensive case management is for homeless? Because it sounds like the psychiatric prescriber goes to people's homes, so that wouldn't be for people out on the streets.
So both teams can serve people that are homeless or housed. The ACT team is a housing first model, so housing first assertive community treatment team, excuse me. And so we work with people from any perspective, whether they're homeless or whether they're housed. But I think the ACT team, one of the primary criteria is that the person is either homeless or at risk of losing their housing with some other criteria. But I will have Zach speak more on this.
Yeah, so our program is actually designed to prioritize individuals who are experiencing homelessness or frequent periods of homelessness, housing instability. And so when I said home, that could mean the shelter, a hotel room, their camp. And so when individuals start with us, when we're kind of prioritizing who we can take on, because as was mentioned, we have a staggered thing. So we only take 4 to 6 people maximum per month on, and that's so we can provide those wraparound services. And our first priority is getting them inside somewhere so that they have somewhere stable, that they can start their recovery, as well as that we have somewhere where we can connect with them and that we can find them and that start building that. And so, we start off with folks 90% or more are currently homeless when we start working with them.
Don't you guys get vouchers as well that are specific for your program? Is there any way you could talk about that if I'm not mistaken? Yeah.
So we did at one point, but we don't anymore. But we're still able to find creative ways to do that. So they weren't directly just for us, but there were some things that we had some priority for applying if they met the criteria for our program, would meet the criteria for the voucher. But even when those are no longer available, they're all being used right now. We're still able to work with folks and find alternative ways. So that first year and a half was primarily individuals who have vouchers, and this last year and a half have been primarily with individuals without. So that means partnering with the coordinated entry system to work with folks who are getting vouchers from other places or other programs, but need a higher level of services than that they can provide or have available. And so we've been able to do it with vouchers and without. I mean, it's definitely easier with a voucher, but that goes back to the partnerships with landlords, with things like that. So we've actually able to have talked to landlords who would be able to reduce rent for, based on the person's income, or to make accommodations for not meeting the 3 times the rent and things like that. So just getting creative, and really those community partnerships is really key.
Cool, thank you. All right, who's next?
Can I just add about
Sure.
the voucher question? So that might have been the third thing that I would have said, is to really look at what are your affordable housing options, meaning programs with subsidies and vouchers. And we didn't really designate vouchers for programs, but we looked at eligibility criteria and the VI SPDAT we used for you're talking about the moving home program vouchers, and eligibility for the ACT team was pretty similar to the VI SPDAT, so that's kind of, that was kind of how we did that. But I'm not aware of any voucher programs that actually go to a program. And I want to add, I always say this, but I'm going to say it again, we have the Department of Health and Social Services has really enjoyed an amazing partnership with AHFC, and we've partnered to try and get vouchers or subsidized housing, and because there's so many different programs, some are subsidized, some are actually tenant-based vouchers, and you can see the results of that. So, for example, Carlick Manor is a subsidized housing first program, but some of the ACT and ICM apartments, they're not really owned by them, and they're a scatter site approach using subsidies. So I just wanted to add that. It is an important aspect. It's a good question.
All right, who's next? Anybody else have any questions?
I have a question.
Sure.
So one of my questions is, one of the things that I learned the most from when I was trying to learn about ACT was going to the daily team meeting. And it's a very, if you have never seen this, I highly recommend it. It's in an hour, they really sort of run through everybody who's a participant or benefiting from the service to kind of prioritize and make sure that everybody on the team is aware of what's going on that very day. And they do it in an hour. It's amazing. So my question, though, for the intensive case management team is, what's the process for communicating with the various team members? Because those are high needs folks as well. So I just wonder what your process is.
Our process is a weekly team meeting where we meet once a week. We meet on Mondays where each case manager would discuss what they're working on with each client and what are needs that are being flagged or clients that need to be contacted because they may not have been in touch with us for a while and they are kind of under the radar for disengagement. So we meet weekly to discuss each client, and with each of the recovery coordinator, I have a individual supervision weekly to discuss more in depth about their individual work with each client.
And if I might, one more question. I know you guys want to go home, right? So, how do you know when somebody is ready to graduate off of ACT and also off of intensive case management?
So how do we know when a person is ready to graduate? Their services are driven by the treatment plan, and we examine how they are doing with their treatment goals, and their progress with their treatment goal would be obvious that they have accomplished certain things, and that they would either need to be stepped down to a lower level of care, whether to get peer support. We often utilize the peer support program at Choices as a step down from intensive case management, or they might need to be step up to more intensive services with the ACT team. One of the in this field, one of the way that we also measure or assign that a person might need to be ready to be discharged is they're doing well and they're not keeping their appointments as regular as before, but still doing well on their own. And that's when you could have a conversation with them and say, hey, it seems like you've progressed well with your treatment goals. You have accomplished getting an apartment. You're working part-time. You're getting medication management, managing your symptoms of your mental illness. You've been sober for XYZ, maybe 6 months or so. And we think that you're ready to move on. What do you think about that? So we'll have that conversation with them, and sometimes they don't want to leave. They don't want to stop services because sometimes they have that separation anxiety. They're afraid that, hey, if I stop getting service, I'm gonna fail. And so that's why we try to connect them with say like peer support, and to also let them know, hey, if you're in need of this service again, just reach out to us and we will gladly re-engage with you. So sometimes it's a fine line. It's really sometimes difficult to determine when a person is ready to be discharged. But some of the indicators to look for how well they are progressing with their goals that they have set and accomplished, and how well they're maintaining on their own in the community?
So this is it's always a tough kind of answer for this, because it's always going to be so different for each person. But a big thing, we're looking when someone's ready to graduate or kind of move on. One is a natural thing. They might, say, hey, I don't need to see you this often, and we kind of start a very, a month or 2 months of them coming in once a week, or once every other week. So there's kind of a natural thing where people are ready to move on. They don't no longer want or are interested in seeing us as much, which is always a great thing. That means they've got other things going on. The other thing too is that we're a recovery model, so we know we're not going to keep folks forever, because we're kind of hoping that during their time with us that they recover and have progressed in their own road to recovery, that they're able to access other services and other things in the community on their own, and without that level of intensity. We haven't quite, and now we're coming into our third year, we're going over that a lot, and so the big indicators, I think, for success in our program is how is someone maintained housing, and as someone engaged with treatment. And so I have a list here. I have people that are reaching up to 1,000 days in their own permanent home. That to me is a really good sign that they've kind of developed those skills and are ready to start talking about that. When we do finally make the decision that someone is ready to graduate, or they make that decision, there's kind of this prolonged thing where like I said, we kind of tried the trial of stepping back, and then there's like a couple month, 3 to 6 month handoff, where if they needed those or things kind of got more intense or acute, they'd be immediately accepted back in without kind of affecting our 4 to 6 month entry kind of admission criteria. And so that way that we're remaining in contact with them. If it's somewhere in-house, we're able to communicate with their current case managers. But if it's outside, we're still kind of checking in with them. We've kind of get their permission to kind of, hey, can I touch base with you when I come by? Or if I'm in the area and I see you, can I talk to you? Can I talk to your landlord, after a while, to see if, how you're doing, and kind of make that plan with them. And it's, like I said, it's a team approach. So we have all the different team members there, kind of in those treatment team meetings, talking to them, making those plans. And so that it's not an abrupt thing, or it's not we won't kick someone out for not showing up to appointments. There's no limit to that. So it's really when the individual's ready to, and when they want to step down. So.
Okay. Anybody else for a last question? All right. Well, I would like to thank our panelists. It was a great job, guys. I really appreciate it, and I hope you all come up to Fairbanks in February for the symposium. Yeah. Awesome. All right. Thanks, everybody. Oh, no, thank you so much. That was great, guys.